Good morning, one and all. I will be presenting the topic is traumatic intralenticular abscess and evolving spectrum of endophthalmitis. The authors have no financial disclosures. The intralenticular abscess is defined as collection of yellow pus-like material within the lens substance which occurs secondary to trauma, cataract surgery, or from a metastatic infection. So in this study, we will be dealing with the traumatic intralenticular abscess, that is the intralenticular abscess that occurs secondary to trauma. So the mechanism is following penetrating injury whenever there is a rupture of the anterior capsule. So if the infection accompanies a purulent infiltration can result in a lens abscess. Lens acts as an excellent culture medium where organism grows luxuriantly. Organisms once in the lens are able to multiply at a rapid rate before they can be reached by the pus cells, thus leading to the formation of a lens abscess. So the unsolved questions in this regard are how to distinguish the lens abscess from a complicated cataract or endophthalmitis. Can be diagnosed without doing a histopathology. What is the importance of status of posterior capsule? What is the importance of vitreous echos and B scan? How to distinguish between vitritis and endophthalmitis, and what is the role of AIOC in these patients? So the purpose of our study was to retrospectively analyze the demographic risk factors, clinical profile, management, and outcomes of these patients, as well as to describe for first time the novel use of AIOC in patients with traumatic intralenticular abscess. The study was done in a retrospective way after approval from the IRB of our hospital. It was done over a period of 2 years in which recorded 169 eyes of patients that presented with open lobe injuries were evaluated, and patients who had a confirmed diagnosis based on clinical examination, AIOC and B scan with a minimum follow-up 3 months were included in the study for analysis. The exclusion criteria was AIOC not revealing a heterogeneous lenticular opacity or with no clear history of trauma. 17 eyes were included and analyzed in our study. The pre- and intra-operative treatment protocols included topical and systemic broad-spectrum antibiotic with or without antifungals from the time of presentation, followed by small incision cataract surgery with or without cornea or corneoscleral tear repair, lens aspirate to send for histopathological analysis, intracameral moxifloxacin or antifungal in form of voriconazole were injected at the end of surgery. Intravitreal antibiotics or core vitrectomy decision was based upon the vitreous involved. So post-operatively, antibiotic and antifungals were continued based on clinical picture and culture results. Steroids were started after a period of 1 week of inflammatory quiescence, but in fungal cases, a minimum interval of 2 weeks was given. So patients were closely followed up after 3 months of inflammatory quiescence, and IOL was implanted as a staged procedure later. So the age of the patients ranged from 12 to 74 years with a mean age of 46.82. There was equal representation from both the genders in our study. The major source of injury were found to be stick, followed by thorn and caterpillar hairs in our study. The mean presenting best corrected visual acuity was 1.82, which improved to 0.63 till the final visit. So the presentation lag was from 3 to 32 days with a mean presentation lag of 8.72. We had only one patient that presented after one, that was on 32nd day following trauma in form of a traumatic endophthalmitis and a secondary glaucoma at the time of presentation itself. So AIOC revealed a dense heterogeneous lenticular opacity in 100% of the patients. Infiltrates between iris and lens were present in 4 patients. There was a breach in the posterior capsule on AIOC in 2 patients. Vitritis was present on B scan in 10 patients, and 3 patients showed progressive vitritis with exudates. Thus, 3 out of 17 patients developed endophthalmitis in our study. The lens aspirate showed bacteria in 7 cases, fungal growth in 3 cases, and was culture negative in 7 cases. Among the bacterial cases, 5 were secondary to staph epidermidis, 1 each of nocardia and moraxella. Among the fungal cases, 2 were secondary to fusarium and 1 was secondary to aspergillus. Coming to the surgical intervention, 6 patients underwent SICS alone with intracameral antibiotics, while 11 patients needed a tear repair with SICS and intracameral antibiotics. Pars plana vitrectomy was needed in 2 of our patients, and secondary IOL implantation was later on done in 15 cases. So the best corrected visual acuity of more than 20/80 was achieved in 15 out of the 17 patients, but the mean BCVA was 0.63. So the 2 patients who had poor vision were the patients who had non-resolving endophthalmitis, out of which 1 ended up in irises. And this was a patient who presented to us with who had a late presentation. Coming to the discussion, traumatic intralenticular abscess may camouflage a complicated cataract. It is mainly caused by penetrating trauma, and the most common organisms reported in studies are Staphylococcus epidermidis and Aspergillus niger, though other rare organisms have also been reported. The sharp objects inoculates organism directly into lens metal by breaching the anterior capsule. This manifests as an intralenticular abscess and anterior chamber inflammation. In these cases, penetration of antibiotics is difficult. Best treatment is to drain the abscess at the earliest along with appropriate intracameral and systemic antibiotics with or without antifungals. The drainage of abscess leads to eradication of organisms successfully, and there is no need of fast planar vitrectomy in all these cases at an early stage. But even with rapid strides and advancement of IOL surgery, primary IOL implantation should be avoided as per our experience in these cases. This prevents possible adherence of microbes on the IOL surface or at the optic-haptic junction. For most of the infection, it remains confined to the capsular bag despite presence of vitreous cells on B-scan. Thus, it is very important to use the role of ASOCT in these patients to look for the integrity of posterior
Sorry to
capsule.
interrupt, Dr. Kirandeep, but the time is up.
I'll just present this one slide, sir. This is important. So, although the infection appears to be confined within the capsule with a clear vitreous, a dumbbell extension of the lens abscess is very important. It should be looked upon.
Time up, please.
Thank you.
Dr. Kirandeep, you need to conclude. Your time is over. Judges, can we have the questions for Dr. Kirandeep, please?
Yeah. Dr. Kirandeep, in your study, significant number of patients are culture negative out of 6 or I think 7.
7 patients were considered.
So why, on what ground you will justify as a abscess? What are the other criteria to say abscess, lenticular abscess in a culture negative? Yeah.
Yes, sir. So the main diagnosis that is based upon the ASOCT. So in ASOCT, we were seeing a heterogeneous lenticular opacity that was taken as one evidence of an intralenticular abscess, even if the culture was negative in these patients. So that was the criteria used. And plus the other thing we want to emphasize was the role of dumbbell sign in B-scan. That is very important and gives an early indication of early endophthalmitis. Even if we are feeling it is only a traumatic lens abscess, we need to deal these patients as an early end of patients.